Hi, good morning, good afternoon, good evening, whenever you're watching this. Um, Module 1, it's two chapters, the first two of the book. Uh, I'm really not going to read them for you because you all probably graduated from second or third grade and can read. And I really don't think there's anything tremendously challenging to discuss. There seems just to be a lot of definitions and a lot of concepts. So my takeaway for you on this is to kind of uh, sit back and relax and think about some of these things. I guess what I'm really asking is this course that talks about community and public health may be a little bit of a change, a little bit of a change up from what you're used to when you talk about healthcare management. I mean, I think we all, if you grabbed a group of students and said, tell me about healthcare management, I think they would all talk about hospitals, physician practices, nursing homes. And I think that there's few of us that would kind of look back with this public health perspective, this whole idea of what health really is. Great definition by the World Health Organization. I think we as people joining into the field, I know I felt this way. Let me see if I can get the center there. Yeah. I felt this way was health was kind of the absence of disease. And we find that that's really not the case. And we look at all the influences of health. There's one of the readings, one of the extra readings is talking about health literacy. I often ponder myself about social issues and say, what is really the root cause of social issues? And is the root cause of social issues in health lack of facilities, lack of money, lack of planning? And I kind of compare this sometimes to education. I don't know if you have kids or worry about schools yet, or are worried about schools, or have worried about schools. But anyway, we often look at school districts and we say, well, wow, gosh, how come there's such a significant difference in school districts? We have in the same general area. And I know I live in Long Island, New York, and if you ever look at the map, Long Island, New York is a long, narrow, 6, 7 miles wide island. And as the communities come out from New York out to the East End, because it runs from the western end of New York out to the eastern end in the middle of the Atlantic Ocean, there's very types of communities. There's some extremely well-to-do communities. You may have heard of the Hamptons and Oyster Bay and all these places. And then there's also some extremely poor communities, socioeconomically, in the whole area. And when we look all the time at New York has public testing. So when we look at the public testing, the areas that are very well to do have great scores, and the areas that are less well to do have medium scores at working class blue collar neighborhoods, and the areas that are pretty much poverty stricken, socioeconomic low classes of people for funds, jobs, education, all those things have the poorest grades. And so you look at that and you go, oh, yeah, I got that. And did you ever sit and kind of chew it out why? This isn't an education course, so I don't want to get into the whole idea, but obviously there's more to it than the money that's funding the school or the teachers that are funding the school. And that's something I can used to be able to put my hands around before I started talking about health. Now you get into health and you find out pretty much the same thing. What we're talking about is an area where we have poverty. We have, and then the book outlines this. We have environment, we have politics, we have social, we have ethnic, we have all these things thrown together. And the one product we're looking to measure coming out of this is health. Now, is that fair? What is the cause and relationship of each one of these? And that's what we're trying to figure out a lot in public health. That's what we try to figure out in everything. I think sometimes we try too hard to find a cause and effect for everything. I don't know whether it's how beneficial it is, but I just don't believe everything's magic. I believe that there are causes and effects for something. So we want to look at different methods, different schemes throughout this course to improve the health of the public, which we've defined earlier as more than the absence of disease. It's the ability to live a productive life. So we're talking about health literacy. We talk about the idea of education. People talk about education being the key, and then that education kind of transfers into improvements in health, in social being, and all that other kind of good stuff. And that line from here you have education to here you have results. That line that goes through the middle there, that's where all the magic happens. So what is that magic and how does it work? And we're going to look to that several places in the course. So we're going to look at what input was being made and what output comes out of it. Interesting, and it should be a lot of fun. But there's, again, we're not in undergraduate school where I would take these first 2 chapters and write a test for you and say, define community and there's some of the other stuff in here, what's 3 different ways of doing this or 4 different ways of doing that. What I want you to take away from that reading is, number 1, the interactions of all the different organizations that have on health. And do they really have an interaction? Is it a symptom? Do they treat the symptoms or is it a cure? There's another article I read earlier this year about the idea of social epidemiology. And they say that good and bad health mirrors the skills that are used in epidemiology. Why, the numbers and learning, and we'll talk about epidemiology a little more in the course. But they said that social factors, lots of factors have a function in disease. And they go into a little bit about genes. So, for example, I guess the one I'm pretty familiar with is the BRCA1 gene that people that have it have a higher, women who have it, and men too, I guess, but have a higher propensity to breast cancer than people don't have the gene. But it's not a 1-to-1. So if you are found with BRCA1, that does not mean that you're going to get breast cancer. It means you're disposed to breast cancer more. And why is that? Why do the genes act some ways in some people and other ways in other people? Why is disease some ways in certain people and other ways? Do you all know somebody that's, and maybe it's you, I hope not, but every winter just has one cold or one flu right after the other, one after the other after the other. And then other people, go through the whole season, never be sick. Look at doctor's offices for you that work in healthcare. How many frequent flyers do you have? How many people that are back all the time for health reasons? Is it because they're in fact sick? Is it what social factors enter into that? I find sometimes a lot of people, one of the keys for depression is that you feel physically sick. You always hear the idea of stress. Don't be stressed out. Stress leads to heart attacks. It seems logical, but is it documented? And that's some of the things the social epidemiologists are going to look at. Is what we can transfer from our milieu, our areas around us, to the idea of disease, and how do we go about changing that? It's what we know and what we don't know, and we have to know more than we don't know, and then from that we have to take action on it. So we talk about this idea of what the relationship from all the social factors are to the biological factors of disease. Now, obviously, if you live next to an asbestos factory, there's some asbestos floating over. You have a chance of getting diseased about that. Just on a personal note, my father, bless his heart and soul, grew up working in an auto repair shop, redoing brake drums. Now, if you're a car fiend, you know this, but if you're not, back in how a brake works is the wheel rolls around and then this thing squeezes on it and shuts it and stops it down. Well, they had these asbestos brake pads, and asbestos was good because it transferred the heat. It didn't burn up with the heat and everything. Well, today you get new brake pads. They take the old ones, throw them away, and put new ones on. And there's some aluminum and all this other stuff in it. It's not quite as bad. But back in the day, they were made of solid asbestos, and they used to be refitted, recycled in today's worlds. And my dad used to take the old brake pads, drill them out, blow them down with air, put the new ones on, rivet them in, and move them on. It was well before the times of respirators and masks and OSHA and all this other kind of stuff. So for about 10 years, when he was a young kid and before the war and after the war for a little bit, he would redo asbestos brake pads. So you say, wow, is exposed to tons of asbestos dust. Yeah, he was. He didn't die of asbestosis. He didn't die of any lung disease at all. So, well, why did he, and why do some people that just get exposed in a minor area of asbestos develop asbestosis? So that's some of the questions we want to look at in public health. How can is there some magic keys that we can turn that kind of make people's lives better? Now, one of them we find out pretty easy is money. People that are richer have less. Now, is it because they're richer? Because they have less stress? Because they have less poor water, poor living conditions? Is it because they have more education? I always used to tell my students when I was teaching undergrads, it's a known fact that people with a college degree live a year and a half longer than people without a college degree. So all you people that are getting degrees are going to live longer. Well, that's kind of a statement that has little validity to it. It's looking for that cause and effect. Having a college degree does not improve your health, or does it? So when we look at this idea of all these concepts here, these are the thoughts I want you to have in your mind and to kind of look at that from that place. What effect does your environment, and I mean both your physical environment, your mental environment, have on your health? And how can we improve that? So that's one of the thoughts for these first two chapters. The second thought for these first two chapters is, now here's a real news flash for you. There's more to health than Virginia, New York, North Carolina. It's a world. And if we don't realize the idea of the concept the world is flat, then we better soon pick it up. I think the last dance we had with the Ebola virus and the one we're currently having with measles and measles vaccination is one that leads you to believe that we better be able to do something with world health. All we have to do is go to JFK, go to Charlotte, go to DC, and stand in the airport and watch all the people coming in and out from different places in the world. And it doesn't, the world is getting to be, I remember when I was younger, somebody went to Europe, they were like A, amazingly rich, or B, kind of like a Lowell Thomas, National Geographic explorer kind of person. But the normal person in the neighborhood that only traveled maybe because their roots were there and they were first generation Croatians or Hungarians, and they were going home to their families. But there wasn't a lot of people that travel. Today, gosh, I have all kinds of friends that, at the drop of a hat, travel internationally. And to all kinds of countries. It used to be you met somebody who went to Africa and it was like, holy heavens, Now, pretty common. Pretty common to meet people from everywhere that have traveled from there to the United States, people from the United States that have traveled there and returned. So when we look at health, we can't be so myopic and so fixed on the United States, because the effect of an Ebola outbreak in Africa, Central Africa, has an effect on us because people fly back and forth. Diseases are transmitted. I don't know if I went to China last year, I think, and as you get off the plane, you know how you walk down to get to your bags. Well, to get to your bags and the customs station and everything, there was an area, and they said everybody take off your hats if you have hats on. And you walk through that area, and it was a whole bunch of scanners up in the overhead that scanned you and took your temperature. And they had to have a bald head; they couldn't have a cap. And if you had a high temperature, they had somebody to pull you out, and they were all wearing masks and lab coats and everything. And I at first looked at that, and I went, "Wow, is this necessary?" But in China, they think it is. We don't do it here. You know, we have a little sign: if you're sick, please tell somebody. But not, you know, there's no requirement. So when we look at world health and look at transportation and look, it becomes more important to us. So now you look at a situation like Fairfax County in Virginia, and how does that compare with a community in Southeast Asia? How does that compare to a village in China? Should we be as concerned with all these health things? It's not. It's not strictly a purview of the rich, which all Americans are, and most Americans are. Excuse me, compared to some other the poor places in America in the world, but those can affect our health as much. And then how do we affect their health there? So that's another question I want you to kind of be thinking about when you're looking at your papers and kind of expanding your. There's a chart in your book, I think, that talks about the how they go about evaluating health, and there's many factors. They look at the cost, the dollar cost, the effectiveness of it, the age, the death, the neonatology, live births, and everything, and they all run these numbers together and come out with a big chart. And it's a fact that's thrown out all the time that the United States rates in the depending on which chart you read in the 20s or 30s for health. And obviously we spend, and you remember this from some of your health economics undergraduate courses, if you took them, we spend more than double the next country, which is Canada, on health. We spend 4 times more than Germany per capita. So why are we 35th and other people are first? And we look at that. Is it lifestyle? Do we... What is it? What changes our health experience as compared to other places in the United States? I read another article here recently that said, well, one of the reasons is we do a much better job in surveillance. We can mash data and we can find out how many people in the United States to a high degree of certainty have a disease, where other countries maybe not so much. We all know if you've done any kind of survey work or where computers, where you pull off the data has an awful lot to do with it. So how do you define neonatology, premature deaths or deaths from infant mortality rates? How do you define that infant mortality rate? Is it someone who dies within the first day? Is it someone who is delivered, a baby who is delivered dead? Is it something that happens in the first week, the first month? So what if a baby dies 2 days after it's born? Is that an infant mortality problem or is that another health problem? And every major health organization, state organization, World Health Organization, measures that time a little bit different. And that really skews the data. So I guess when we start looking at things, I want you to look at them with a very cynical eye. Drive it down to the base, and this is kind of good advice for everything you do. we've become so much of if it's on the computer screen, it's written from above. We find that we believe, the I don't want to. I try to stay unpolitical in the world, but I won't call it fake news. I'll call it lies. How many things have you read on the internet or in sources that you find later were just not there? It's like reading those when you go to the supermarket to check out, and you find out that Tim McGraw and Faith Hill have been being divorced now, I think, for about the last 22 years. It's always Faith Hill, Tim McGraw. I don't want to get ridiculous about this, but think about that. Think about how quickly you look at data and believe it. As a graduate school at Mizzou, I have a degree in public health. We had to take an epidemiology course, and we took it with the half healthcare management people and half medical students. And it was really interesting. We would take the professor was a physician, and PhD, MD combined, smart guy. And he used to take studies and give them to us, and that was our job, is to critique them in teams and then make presentations to the class. Well, obviously he didn't give us the best studies in the world, and there were flaws, but these were published studies. I mean, these weren't case studies that were made up by somebody. These were studies in the scientific journals and critiques and such. And we all found, and a bunch of bozos, not that you guys are, but we were as graduate students without a lot of experience. We were finding flaws in these reports. So you watch the evening news, and there's a report out that coffee is one of my favorite things. Over the last 5 or 6 years, coffee has caused cancer. Excuse me. Has caused cancer, has caused heart disease, has caused high blood pressure, has cured cancer, has lessened the effect of cancer, has lessened the effect of high blood pressure, has lessened the effect of heart disease. And I've gotten these all off the TV because they're studies done by somebody. This whole anti-vaxxer movement, which I hope nobody that's listening to this ever thinks about it being an anti-vaxxer, because you're an idiot if you do, and I'm sorry I'll say that, but it's all based on one study which has been proven time and time again to be wrong, done by a British doctor who was found to be paid to do it. So, but it made the headlines. So people, we aren't critical enough in looking at studies and looking at things, and that's kind of back to my whole theory and what we're going to school for. Where do we get the information? And is the information an apple to apple, orange to orange comparison? You always hear people, that's one of those cliches. We need an apples to apples comparison. You really do. Quick story. I was doing a study in one of my practices, and we had the report writer program with our super duper computer system, and it was before the days of electronic medical records, so it was in business record. We were using billing records, and I wanted to know how many patients we saw, what was the average cost per patient, and the average charge per patient. And so I gave it to my CFO, and he was the big report writer guy, and he comes back a little later with the number of patients and the number of patient visits and the number of the charge per patient visit, and it was like $8.43. And I went, wait a minute, we know it's more than that. It's just logical. And we started looking, and the real problem was, what is a patient visit? And we looked, we would just write a program, a report writer, and say, give us the number of patient visits. And those patient visits would pop out of the computer, and we would go, okay, there's the patient visit number. Where did that number come from? Now, you guys that are familiar with healthcare know that every time a patient walks in and we register them, That that's does that count as a patient visit? What if they never see the doctor? What if it's a person who has surgery and for 90 days after that, there's no charge for the visit because it's an included cost of the surgery, and they come in 4 times? Is that 4 patient visits with no revenue? Is that how the computer figures it out? What about people who get the register and sit in the waiting room for 15 minutes, say, I can't wait anymore, and leave? Are they patient visits? Where do we pull the string on patient visits? We spent a month and a half trying to figure out where these numbers came from, looking at the computer and getting down even into machine language. And that's the point I guess I want to make is when you start looking at data, start looking at these coffee causes cancer, or we're making $3 a patient. You have to go back and look where those numbers came from. Where are you comparing things that are exactly the same or different? And the article on infant mortality was that the United States counts infant mortality up through the first month, and where other countries only count it on the first day. So big difference in infant mortality. We have 30 days worth of data compared to their 1 day worth of data. So obviously they're going to do better than we are. Because some babies linger for, and especially with modern medicine. So again, when you start looking at data and see we're 35th and you want to run around and yell and scream about that, start looking why you're yelling and screaming. So to kind of wrap it up, I told you this was going to be short and I could probably go on forever here and bore you to death. The real tricks that we want to look at are the definitions of terms and organizations that are involved, because they're now going to become building blocks for the rest of the course. We want to look at what exactly we're talking about in public health and why is it important, and then what's the scope of it. We have a hard enough time working public health in the United States. Can you imagine the idea of working at World Health Organization? The politics and the involved in this must be horrible. I mean, again, not making a value judgment, but we've had presidents that have thought of ourselves as great world leaders, and we've had other presidents that thought of ourselves as very insular, very America first, and we'll take care of ourselves before we go outside the gates. So how do we do world health when there's tons of countries that think that way? How do we compare world health in a nation like the United States that has the highest standard of living to a nation like Belize, or to a nation in Africa that doesn't have that standard of living? It doesn't have schools and public health departments and all that. So how do we do all those things? And those are the thoughts I want you to kind of look at. The question this week is, what is the challenge for 21st century? There's lots of good articles that you could Google up, Google Scholar if you use it, or go to Mary Baldwin Library, which is one of my big fantastic places to go, and start looking at some of the things that people are talking about when they're talking about public health. It's a tremendously complex area, and at the same time, it's kind of a gateway. It's kind of a way of thinking that should pervade your entire career in healthcare, both if you're going to be in hospitals or physician practices or such. It's not a pie in the sky. And in fact, I offer you, in some cases, poor management of public health could have a much bigger effect on the day-to-day stuff that we do than we'd ever think. Okay, I'm going to sign off for now. Please, if you have questions, drop me a line, email. I'll answer quickly. There's a little gadget on the Ask the Professor on the course module, which I look at, and it sends me an email when you put something in there. Phone, you have my phone number. I'll probably this week do a live on Thursday, and I'll put some time up for that. As I talked about in the intro, I'll be there. If you want to be there, fine. If you don't want to be there, that's fine too. I want to give you as many opportunities And if you just want to call up and discuss what we talked about today, your opinion of it, fine. Uh, we're also going to look at maybe a little bit of manipulation on topics for the discussion boards. I got a comment from Catherine about. I mean, after a while, these get to be pretty perfunctory. You put a question, 2 comments, and then you're done. We want to make these more of an exchange and learning period. So, anyway, that's all I have, and hope to see you next week with maybe a little more lecture now, where we're going to get a little busier. But I just didn't want to read you the lecture, and you got all my lecture notes on there, and I think between the two of those, and hopefully this has been a little helpful too. Okay, thanks very much. Talk to you later.